All right, we're going to be discussing some of the common medical conditions in patients we encounter. In the hospital, the focus is on, making a diagnosis and treating the patient. And so, important concepts like troubleshooting when the patients are not responding, making sure that you don't misdiagnose a patient, which can have really expensive repercussions. So we're going to dive into some of these covered topics like pneumonia, cellulitis or soft tissue infections involving extremities, acute and subacute heart failures, intra-abdominal conditions, and of course, initial chest pain evaluation. These are some of the common conditions that we meet in the hospital, and I'll quickly go through some of the special situations you want to consider for these conditions, so that you don't run into any kind of trouble. So for the pneumonias, I'm going to focus more on, situations in bilateral pneumonia. So, of course, to manage pneumonia, you have to take your history, you have to do your examination, your lab tests, you have to do your imaging, and you make the diagnosis. But special considerations should be made in patients with bilateral pneumonia, which you can see when it's reported on the chest x-ray. Okay, so you have to consider special situations, including special forms of pneumonia and pneumonitis that may require further evaluation, like aspiration pneumonia, so that you make sure you address dysphagia in these patients. Atypical pneumonias like COVID-19, mycoplasma, some cryptogenic pneumonitis, immunodeficiency states. So these require a little more evaluation in assessing these patients. You have to consider alternative diagnoses when you see bilateral pneumonia. You have to consider acute respiratory distress syndrome, your ARDS, pulmonary edema, other rare conditions like diffuse alveolar hemorrhage, pulmonary infarctions in pulmonary embolism, and this may require additional CT scans or specialty consultation. The pulmonologist to make sure you're not missing complications or alternative diagnosis. Let's move on to cellulitis. This is an interesting one. People who come in with soft tissue infection. So in addition to taking a thorough history examination on how it's started, the limbs were involved, you have to assess the neurovascular bundle in your examination. Very important. Look for signs of deep tissue involvement like cyanosis of the fingers or toes, discoloration, open wounds in your inspection, temperature differences between limbs, sensory loss, abnormally tense muscles in your palpation, difficulty palpating distal pulses like the radial or digitalis spesis pulses, or loss of motor function. You need a high index of suspicion for conditions like necrotizing fasciitis, critical limb ischemia from embolizations, DVTs, arterial thrombosis, tenosynovitis for the hands, compartment syndrome, polymyositis. And so in these cases, if you see any of these red flags in your examination, you want to get additional imaging or, vascular or surgical consultation if you have concerns. Because these are, again, diagnoses you definitely don't want to miss. These are diagnoses that if you miss, they can lose a limb. And this is, this will be a liability issue. So you want to be very careful when you assess these patients with, so-called cellulitis or soft tissue infections. Moving on to the heart, for people who come in with acute or subacute heart failure, it involves more than just diagnosing them and giving them diuretics. You have to consider the scenario, the attention to onset of symptoms, the rapidity of the progression in your history taking, determine the root cause of the heart failure. What's the trigger? It's more important sometimes to reduce mortality than just the diagnosis of heart failure. And so, take time to get a good history. Did it come on suddenly or did it, take a while? So for the hyperacute and acute cases, you have to think of triggers, events like myocardial infarction, pulmonary embolism, aortic dissection, ventricular arrhythmias, hypertensive crisis. And so, if this was of a sudden onset, you definitely want to look for these, major events and treat them. For the subacute ones, they are more slowly progressive, and usually causes would be a progression of an underlying cardiomyopathy, poor medication or dietary compliance issues, inadequate diuretic regimen due to patient weight, or on that underlying advanced kidney disease where they are not having good diuretic response, or failure to treat underlying conditions like poorly controlled hypertension, sleep apnea, or coronary artery disease. So you want to watch out for those. Now, for intra-abdominal conditions, most people will come with nausea, vomiting, sometimes with diarrhea, sometimes with abdominal pain, and you want to rule out intra-abdominal conditions that may be life-threatening before you treat conservatively. So in intra-abdominal conditions such as acute pancreatitis, cholecystitis, diverticulitis, bowel perforation, pyelonephritis, and the list goes on. You want to have a suspicion for them once you see any kind of red flags. Most cases are just toxins or viral gastritis, gastroenteritis that supportive management with fluids, electrolyte replacement, bowel rest, and antiemetics will solve. But if you notice any red flags, which we are going to talk about, then you definitely want to get a CT scan of the abdomen, which is about the best abdominal imaging you can get in these cases. So the question is, what are those red flags? What are those red flags that you will see in patients coming in with abdominal conditions that would make you get a CT? So, of course, people coming in with fever, abdominal pain, abdominal distension, bleeding like hematuria, hematochezia, or those who are septic with elevated WBC counts, or hypotensive, hemodynamically unstable, you definitely want to get a CT scan of the abdomen and pelvis to look into that, because ignoring these red flags will lead to missed diagnosis and increased mortality. And so, of course, once you rule out the organ-specific conditions we talked about, then you can just manage supportively. Now, how can we discuss without talking about chest pains? It's the common reason for ER visits globally. You need a good history and physical examination, and you need to watch out for life-threatening conditions. Most chest pain admissions tend to focus on cardiac causes, acute coronary syndrome, but you have to consider conditions like an aortic dissection, acute pulmonary embolism, and you can see even screening algorithms like HeartScore tend to polarize to cardiac causes without looking at the pulmonary emergencies. So some of the things you want to watch out for: hemodynamic instabilities, hypoxia, elevated blood pressure can point to alternative diagnoses like dissection or pulmonary embolism. And so you want to consider additional imaging like a CT angiogram of the chest, for instance, when you suspect these killers like the dissection or pulmonary embolism. As you can see, these are conditions that are life-threatening, that if you miss them, patients can actually die. So while we don't neglect the usual cardiac cause of acute coronary syndrome, you want to look at all these other conditions. So what the take-home points for this lecture would be, one, you have to definitely make sure that your diagnosis is right. You want to make sure that you have a good knowledge of differential diagnosis for different presentations. So consider the worst case scenario in all clinical presentations. Think of the killers and make sure that you've ruled that out. Of course, consider alternative diagnoses and trust your instincts. If you are worried that it might be more than just a cellulitis or more than just a regular chest pain, then go ahead and do some further evaluations or tests. Have a high index of suspicion for these uncommon conditions like necrotizing fasciitis in cellulitis. And for things like heart failure, focus on the primary cause of the diagnosis rather than just the treatment. What triggered the heart failure? You want to focus on that depending on the scenario than just the diuretics. And of course, it never hurts to get a specialty opinion when in doubt. It's not a sign of weakness. Two heads are definitely better than one. So if you feel it might need a specialty, go ahead and consult.